Philadelphia. We are delighted to have all of you here. Before I forget, my staff have reminded me to make some announcements, and you never want to get in trouble with your staff. There are still tickets available for the gala on Friday evening. For those of you who have not attended, it is not a rubber chicken dinner. It will be great fun. We have delightful honorees, including Simon Estes from the Met, Cicely Tyson, Walter Williams, who's lead singer for the OJs, and Karen Hepp and Lauren Johnson, who are local news anchors. So it will be lots of fun, big band, dancing, singing, all kinds of stuff. So if you are interested, there are a few seats left. There are also a few cancellations and changes in the program, so please look at the errata sheet that you were given when you came in. This afternoon is the only true tutorial portion of the program. It was introduced a couple of decades ago for people who were not expert in all of the many fields here, and especially as an introduction for our first-time attendees. Hopefully, it will provide for singers who are not voice scientists and physicians who are not voice scientists enough basic overview understanding and vocabulary that you will be able to enjoy and more or less understand the papers that are presented throughout the week. How many of you are here for the first time at the Voice Foundation Symposium? Outstanding. A wonderful group. So without further ado, we will proceed to the educational part of the program. The anatomy of the human voice is extraordinary. In a moment, it can convey the terror of a scream or the beauty of a song. It is an ancient instrument, and you would think that our understanding of the voice would date back to Hippocrates or before. But surprisingly, it doesn't. Much of what we know about the voice has been learned since the mid-1970s, and a great deal of it in the last decade or two. The voice is exceedingly complex. It involves not just the region between the hyoid or tongue bone and suprasternal notch or top of the breastbone, but all body systems. Singers know this. Speech pathologists sort of know it. And otolaryngologists hopefully learn it as they become more interested in laryngology. But if you look at any singer, you can see that all of the singer is involved. For those of you in the room who also have gray hair, that's Bruce Springsteen. He sings rock-type music. The larynx receives the greatest attention, not only because it's the part on which we get to operate, but also because it seems as if it is the most personal part of the voice. Yet it is not even essential. Our laryngectomy patients phonate perfectly well and perfectly understandably. The larynx is necessary, however, for normal and certainly for Olympic voice. For convenience, the larynx can be divided into skeleton, mucosa, intrinsic, and extrinsic muscles. It is useful for all of us to understand the anatomy of the voice so that we can think more incisively about what is wrong and what is right when we are working with voice patients, clients, or students. Because really what we do in the laryngologist's office, diagnose, figure out what's wrong, why it's wrong, and develop a treatment plan is the same thing that a speech-language pathologist does and the same thing that a singing or acting teacher does. In the singer world, we have traditionally been remiss in not even knowing the parts of our instrument. Any violinist can tell you the difference between the bridge and the neck, but there's still singers running around who think the vocal folds run this way. Knowing better than that is helpful in a practical sense. So that is one of the reasons that we are having this discussion today. The skeleton consists of the thyroid, cricoid, and pararytenoid cartilages, and some other cartilages and structures that are less important. If you are new to voice anatomy and haven't had a voice pedagogy course recently, if you can remember thyroid, cricoid, and arytenoid, and just a couple other things I will tell you, you will be able to pass the multiple choice test. Anatomists are not terribly creative, so most of what we will talk about is named after these cartilages. This is a side view. Here's the thyroid cartilage, and you can see goes through it the cricoid and arytenoid cartilages. And behind them, the spinal column, which contains the spinal cord. The larynx at birth is high in the neck, around C2, C3. Over the course of maturation, it develops a descent to around C7. That lengthening of the vocal tract is part of what our ears perceive as voice maturation. In addition, you'll note that behind the cartilage is bone with only a little bit of intervening pharyngeal soft tissue. When we are born, the laryngeal cartilages are cartilage. As we age, they ossify, they turn to bone. So that by the time you are an old person, such as I, your larynx has become brittle. So if a teenager sustains laryngeal anterior neck trauma, the larynx is pressed back against this unyielding spinal column, but it is pliable, it's cartilaginous, it is apt to bend and spring back and much less likely to fracture than an old person's larynx. If you are, how many laryngologists in the room? Good, we have at least some physicians. Another practical use for that knowledge is if you are doing surgery on transgender patients and want to do a cricothyroid approximation or subluxation and you're working with somebody relatively young, you can do that. If you're working with somebody 50 or 60, the cartilages are not flexible enough to allow the cricoid to slip under the thyroid cartilage in most cases. This is a side view of the larynx, split down the middle. Now you can see that the cricoid cartilage, small in front, large in back, is circumferential. It goes all the way around the airway and is the only structure to do so. The tracheal rings and the thyroid cartilage are horseshoe-shaped. They are open in the back. In the front, the thyroid cartilage has a prominence called the thyroid prominence or Adam's apple. It is there in men. It is not ordinarily there in children or women. In children or women, the cricoid cartilage is the most prominent structure. If you feel the front of your neck and you're female, you'll feel the cricoid cartilage and no protrusion here where the Adam's apple is. If you look inside the larynx, you see the epiglottis. And here you see a white structure that runs from the inside of the thyroid cartilage to the vocal process of the arytenoid cartilage, mislabeled vocal cord. Please remember that. First of all, we stopped using the term vocal cord in favor of vocal fold several decades ago. And second of all, this is neither the vocal cord nor the vocal fold, but we will refer back to it. So keep it in your mind's eye. The laryngeal cartilages are attached by joints, the cricothyroid joint and the cricoarytenoid joint, that are synovial. They are made of the same materials as your elbows and shoulders and knees and subject to the same afflictions. Infection, arthritis, dislocation. These joints move in multiple planes. They're not screw-like joints. They have pliability. So that when the cricoid and thyroid come closer together, a lot of different things happen, including movement in the joints. So we are not very good at restoring that complexity when it's injured or damaged. Here is the hyoid bone, thyroid cartilage. There was a membrane in between them that has been removed here, cleverly called the thyrohyoid membrane. Again, if you remember thyroid, cricoid, arytenoid, and hyoid, you have most of it. There's the leaf-shaped epiglottis, which keeps the beer out of your airway when you swallow. If you remove the cricothyroid membrane, the space is a little artificially widened. You can see the signet ring-shaped cricoid cartilage, and perched atop it, the pyramidal arytenoid cartilages with their apices, muscular. Really? Huh. Okay. For the AV people, I just found out from Ron that the computer is set up so the pointer that I have been using only shows on my monitor. So perhaps at the break, we can fix that. Thank you, Ron. However, I have been pointing meticulously to all the things that I wanted to see. So those of you with imagination, cricoid, thyroid, arytenoids, apex, muscular process, and vocal process, to which is attached that white structure that was mislabeled vocal cord. This is a view from above. Anesthesiologist, you know, surgery I can do, computers. Anesthesiologist eye view. So this is front, back, right, left, hyoid bone, thyroid cartilage, epiglottis. This is a human specimen. That white structure that was mislabeled vocal cord attached to the vocal process of the arytenoid cartilages. There is an embryologic fusion plane where the vocal process attaches to the body of the arytenoid. They are from different embryologic sources. It is a fracture line waiting to happen. It's amazing that we don't have vocal process emulsions more often than we do from intubations for general anesthesia, but they do occur. And it is also the reason why we as surgeons never put an instrument underneath the vocal process and lift. For example, in an anterior arytenoid dislocation, the technique is entirely different from that. If you did the obvious, easy thing, put a right angle instrument under there and lifted the cartilage back into position, you would almost surely rip off the vocal process and detach the vocal fold. The arytenoids move in complex motion. We used to call it rotation and gliding and other things. It's sort of a complex revolution that I will show you in a moment. Now remember that the arytenoids sit on top of the cricoid, which is a curved structure. These are again human. These are x-rays from Jean Abitbol and Albert Castro. You see a little joint space here. It looks just like a little temporomandibular joint. Easily injured. This is in adduction during phonation. When you breathe, your vocal folds move laterally and your arytenoids don't just separate. See how they slide down the curved cricoid surface. Very complex motion. Let's see if this works. So if you look at that move, this is a CT from a living person. It's animation done in Paris. There's the arytenoid cartilage, there's the cricoid cartilage, and there is the point of attachment. And here it is in a slightly different view. When you realize how delicate the attachment is, it is astonishing that we don't have dislocations and subluxations far more frequently than we see them. The intrinsic muscles are responsible for adduction bringing together, adding together, abduction, pulling apart, and longitudinal tension. For your multiple choice test, you only need to remember the superior laryngeal nerve innervates the cricothyroid muscle. If you can remember superior laryngeal nerve and CT, then everything else is the recurrent laryngeal nerve. And by the way, none of that is strictly true. It will, however, get you through the test. The posterior cricoarytenoid muscle, or PCA, is the primary abductor. When you breathe, you fire the PCA and pull your vocal folds apart to get air in. Everything else is designed to protect your airway and incidentally to allow you to sing. Cleverly, the posterior cricoarytenoid originates from the posterior surface of the cricoid muscle and inserts into the muscular process of the arytenoid. And when it fires, it pulls the muscular process so that the vocal process with the vocal fold swings out and up, which brings us to an important point. Each of these intrinsic muscles has an effect beyond gross motion. They affect the edge of the vocal fold. Here's the posterior cricoarytenoid. The dotted line is neutral position. So as you saw, when you rotate out and up, you elevate the vocal fold a little bit and sharpen it. The vocalis muscle runs parallel to that white line that is mislabeled vocal cord between the thyroid and arytenoid cartilage areas. So what do you think happens when you fire that muscle? What moves? Nothing moves. It bulks up. It's an isometric contraction. And that's what provides lateral resistance. So when the left vocal fold hits the right vocal fold, it doesn't knock the right vocal fold out of the way because that isotonic contraction prevents that from happening. That's one of the reasons why when we give somebody botulinum toxin for spasmodic dysphonia, we almost never get normal voice. We get normal rhythm, we get normal flow of phonation, we don't get interruptions. But if you do that with singers, when they try to raise volume or sing loudly, the voice breaks up because you don't have lateral resistance. You can't hold the vocal folds firmly for consistent entrainment of the air as it passes through the vocal folds because you've disturbed that function. You can also have isolated thyroarytenoid or vocalis muscle paresis without weakness of other branches of the recurrent laryngeal nerve. The thyroarytenoid muscle, medial branch, is the same as the vocalis muscle, and it's the one we were just talking about. There's also a lateral branch. There is a branch to each of these muscles, and knowing where the thyroarytenoid branch is can be helpful to surgeons treating spasmodic dysphonia refractory to botulinum toxin because you can cut that nerve and help spasmodic dysphonia without paralyzing the whole vocal fold. The lateral cricoarytenoid muscle swings the vocal processes to the midline. It works in concert ordinarily with the interarytenoid muscle, which I will show you in a minute. So if you're doing laryngeal electromyography and you put a needle in the thyroarytenoid muscle, you'll hear a steady stream of output. If you're in the lateral cricoarytenoid muscle, there'll be a peak as it swings the vocal fold to the midline, and then it will drop off because it doesn't have to work very hard to hold it there. That's important because there are some conditions, like recurrent granulomas, for which we inject botulinum toxin into the lateral cricoarytenoid muscle. And that's how you find it. Why do we do that? Because ordinarily the interarytenoid and the lateral cricoarytenoid work in concert so that the face of the arytenoid comes together more or less over a broad surface. If you have an LCA dominant closure pattern, so the vocal processes hit first, and then the rest of the posterior closure happens, There's an area of forceful contact at the vocal process, and that's one of the reasons for recurrent granulomas that end up getting operated on 6 times, and you treat them with Botox, sometimes even without having ever operated on them, and they go away if that is the cause of the granuloma in that particular patient. This is the interarytenoid, which closes the posterior glottic chink, which you don't necessarily want to do. It works ordinarily in concert with the lateral cricoarytenoid to get a relatively broad closure pattern. The cricothyroid muscle brings the cricoid and thyroid closer together. In so doing, the cricoarytenoid joint gets rocked back a bit so the vocal fold stretches, it becomes elongated. And that's how you change pitch. It also is responsible for projection of your speaking voice. The cricothyroid muscle is innervated by what nerve? Superior laryngeal nerve, correct. One little nerve going to one muscle with no help from other structures. So superior laryngeal nerve is much more common than many people realize, and often is responsible for voice problems. If you look hard enough, you will find it more often than you might think. The intrinsic muscles are suspended among the cartilages that we discussed, and we talked about the fact that the joints have pliability. They're not like screws, they move. So when you accordion the cartilages together or pull them apart, the distances and angles among the cartilages change, hence the resting lengths of the intrinsic muscles change. That is one of the reasons why in classical Western music, in which we value uniformity of quality throughout range, we are trained to keep the larynx at a relatively constant level throughout pitch. That's one reason. Maintaining the length of the vocal tract is another. That's not a requirement for health, I hasten to add. As much as we classical singers don't like to admit that, there are other healthy ways to sing. Rock singers break into falsetto, for example, all the time, and it's aesthetically acceptable, but they are also amplified. They're not trying to fill a 3,000-seat hall and singing loudly. So maintaining the laryngeal position, vertical position in the neck, is accomplished by the extrinsic laryngeal muscles or strap muscles. Here's the thyroid prominence and thyroid cartilage, and here are the muscles in the neck that stand out in your average, mediocre Heldon tenor. Easy to see. Are you all still awake out there? I didn't even get a smile. Tough audience. Any minor damage to these muscles can have an effect on the voice. For example, this is the thyroid gland. I won't ask for a show of hands, but it is likely that some of you already have had thyroid surgery, and certain that some of you will have thyroid surgery during your lifetime. For singers and actors and other voice professionals, we stress the importance of retracting these muscles rather than cutting them. Cutting them makes it easier to get to the thyroid gland surgically. Even if you sew them back together, you get a little scar, and when it contracts, the muscle shortens ever so slightly. You would not think that a 1/16 or an 1/8 of an inch would make a difference. What do you think would happen if you put an 1/8 inch lift in one shoe of a marathon runner? Knee pain, hip pain by the 16th mile? Very likely. So if a classical singer drops his or her larynx to the position of singing and it torques a little bit because of an abnormal strap muscle, it may very well be responsible for dysphonia. There are more structures than the vocal fold alone. We have true vocal folds, above them the false vocal folds, between them a pocket called the ventricle or ventricle of Morgagni. This is cut sideways, as was the picture I showed you early in the talk. This is cut frontways. Excellent. Here are the true vocal folds. There's the vocalis muscle. The false vocal folds, the ventricle. Note that the true vocal folds have a lot of vertical height. Many people visualize the vocal folds in 2 dimensions, like a couple of pieces of paper next to each other, but they're not like that at all. They are more like fingers together. And they're not like that either, but they're more like that. Note that the area under the vocal folds is convergent. That is, it comes together like a steeple. That shape is extremely important to the aerodynamics of the system. If, for example, someone has a thyroplasty, an operation for vocal fold paralysis, that moves the vocal fold together nicely, but excessively squares off this area so that it's a block rather than convergent, the vocal folds will come together beautifully and your stroboscopic examination will look like you did a wonderful job, and people will be strained and unhappy because of the aerodynamics of the system. This convergence is critical to vortex formation and a lot of other things in the aerodynamics of the system. The vocal folds may be divided into a musculomembranous portion and a cartilaginous portion. At birth, they are about 50-50. In adulthood, it's about 3/5 membranous and 2/5 cartilaginous. In old otolaryngology teaching, some of which unfortunately persists, we were taught that the musculomembranous portion was phonatory for talking and singing, and the cartilaginous portion was respiratory. Here's a picture of a live human. Musculomembranous portion, cartilaginous portions back here, originoids, epiglottis, true and false vocal folds. The laryngologists who have been around a while have seen people with webs, that is, scars that approximate the true vocal folds, sometimes the entire musculomembranous portion, and those people can still talk. And when we look at them under stroboscopy, the mucosa in the cartilaginous portion has pretty decent mucosal waves and can function as an oscillator. So we know for sure that under pathologic circumstances, the cartilaginous portion can function very effectively. We don't know whether it functions as part of the system even in high-performance singers. So the reason I stress this, particularly for the laryngologists in the room, is we were trained to be very delicate with the musculomembranous portion, but if we have a granuloma or something in the cartilaginous portion, we're sort of trained that it's all right to just go in with a laser and burn it off. I would submit that until we know a lot more about how this portion of the larynx behaves under extreme use, like opera singing, that the entire vocal fold should be treated with the same respect that we showed in the middle of the musculomembranous portion, and we need more research in this area. The covering of the vocal fold is wet, it's lubricated. It has a special kind of epithelium, stratified squamous epithelium. The whole rest of the respiratory tract has little hair cells on it, it's ciliated. If you took those delicate little hair cells and banged them together 200 times a second, they wouldn't last very long. So the contact areas are designed with different covering that will withstand contact. The lubrication comes from a combination of glands, most of which are not on the edge of the vocal fold. They're in the saccule and above the vocal fold, although sometimes they are on the edge. And there are serous and mucinous glands. The serous glands secrete a water-like thin substance, and the mucinous glands a thick substance, and they mix to create a lubricant, just like your motor oil, of the correct viscosity. There are many things that we do that we think of as drying the voice that do not actually dehydrate the voice, but shift the viscosity balance from serous to mucinous, like antihistamines, thickening the oil so it becomes less efficient. The vocal folds can't come together and particularly pull apart with the same efficiency. It increases cell damage, it increases vocal fold fatigue. And it's a matter of viscosity. So among other things, when we drink lots of water, we're driving the system back toward a serous predominance. We do the same thing when we use drugs like guaifenesin, Mucinex, and Robitussin, and the like, to thin the voice, which helps as long as it's accompanied by adequate hydration. This is a slide from Minoru Hirano, who in Kurume, Japan in 1975 described the structure of the vocal fold. Before that, we thought that the vocal fold was just wet stuff over muscle as the inside of the cheek, the buccal surface. It isn't. This is the space between the vocal folds. The other vocal fold would be over here. The vocal fold is epithelium, superficial, intermediate, and deep layers of lamina propria, and our friend of the vocalis, or thyroarytenoid muscle. The space between the vocal folds is called the glottis. Now, I told you before, anatomists are not terribly imaginative. I like to fantasize that this is the one place where anatomists got a little smile. The glottis is a space, it's the reference point of this anatomy. When you bring your vocal folds together to talk, it doesn't exist. There is no space, there is no glottis, and everything is either glottic, subglottic, or supraglottic from a non-existent structure. The cover of the vocal fold, the epithelium and the superficial layer, also known as Reinke's space, make the mucosal wave that glides over the vocal fold. The vocalis muscle, as you already know, provides lateral resistance. And this transition layer, intermediate and deep layers of lamina propria, also is called the vocal ligament, and that is the white structure that was mislabeled vocal cord, around which the vocal fold is built. So we've already had our first hint of the vocal fold anatomy in layers and function in layers, the mucosal wave. We also learned about wound healing in layers. There are very few fibroblasts and other substances that make scar in the epithelium and superficial layer, but the vocal ligament and muscle are rich in such structures. So if you traumatize them, you have fibroblast proliferation, and this entire elegant layered structure is obliterated. We also figured out that pathology occurs in layers. Nodules, cysts, many other benign lesions involve the epithelium or the superficial portion of the superficial layer of lamina propria. So we developed surgical techniques and surgical instruments that allowed us to operate in layers, removing those superficial structures without traumatizing subjacent structures and provoking fibroblast proliferation. And that's why when you need voice surgery now, your chances are much better of coming out with a good result than they used to be. All because of science, anatomy, and physiology translated into clinical practice and technique. So how many of you lie awake at night wondering how the epithelium is attached to the superficial layer of lamina propria? Well, it turns out there's a basement membrane. And that basement membrane is very complex. It has type 7 collagen fibers that emerge from and reinsert into the basement membrane, through which pass type 3 collagen fibers, which keep the epithelium from flying off the vocal fold, unless you have a disease like dermolysis bullosa et dystrophica, in which case that happens. This and many other things are terribly complicated, and when disrupted can cause different degrees of impairment in different people. I'm not talking about surgery in this program, but I will remind you that I introduced the concept of microflap in the early 1980s, before we knew any of this, which was discovered by Steve Gray as his resident research project at Iowa. And it was better keeping the epithelium than stripping it as it had been before, but we had people who had scar where they hadn't had lesions. Then we discovered this, and then we invented the mini microflap, which limited surgery only to areas already involved, because raising a microflap disrupts this structure, and some people will tolerate it, and some people don't do very well after it at all. Another direct application of science to the operating room and patient care. So, how does all of this actually work? The vocal folds form an oscillator. They make a noise which passes through our resonator system and which doesn't occur unless we get power from the power source of the voice below the vocal folds. So physiology means, how does it work? The power source, the oscillator, and the resonator all work together, and they're controlled by the brain. Even in tenors, they're controlled by the brain. Now, we could spend the entire week talking about neurolaryngology, our newest field, but just think about this. If you want to say something or sing something, you draw on auditory memory, you target the sounds that you want to have come out, you preset the entire system, you utter a sound, and you listen to it, and within milliseconds you adjust it to target. And if you're a trained singer and you are in a noisy environment, for example, a choir, you learn how to do that by tactile feedback. That is, singing by feel rather than by ear. An extraordinary and complex process. Again, it is disrupted by some neurological disorders. It's really surprising that it isn't disrupted more than it is, and I would love to have more time to talk with you about all of the neat stuff in neurolaryngology that affects our patients and students. But we'll just stick to the overview because the real experts who come after I finish will go over most of this with you again in greater detail, and they in large measure are the people from whom all of us learned how the voice works. So the singers and actors in the room understand that the breath is the voice, but that just sounds like a cute phrase to most laryngologists and some speech language pathologists, but it isn't. Breathing and supporting are critical. We use a combination of active and passive forces. You, those of you who are still awake, are inhaling actively and then relaxing. And the passive recoil of your system lets out some of the air. I, however, am up here pontificating and am expiring actively using abdominal, back, and chest muscles to support the airstream and my voice. And that's what we mean, and what singers and actors mean, by support. The inspiratory muscles primarily are the diaphragm and the external intercostal muscles between the ribs. And the primary muscles of expiration are the internal intercostals and chest and back muscles. So how do we do all of this? Pretty simple, even though it's sort of physics. Think about this. Let's take a balloon filled with air, and your task is to squeeze the air out of the balloon in a controlled fashion. How do you do that? You squeeze the balloon, you bring your hands closer together, and the air squirts out. That is to say, you have a fixed volume of gas, you make the container smaller, so the pressure in the gas goes up, and that forces it to escape. Incidentally, if you want to do that, do you want a nice full balloon, or do you want a half-empty squishy balloon? You want a nice full balloon. You almost don't have to move your hands. You just kind of have to think a little bit, and you get enough pressure because of the air movement, which has something to do with breathing technique and why the old singing teaching inverse pressure technique failed, because people were running around with collapsed chests and trying to do abdominal breathing only with no reservoir against which to work. The vocal folds themselves come together and pull apart also with extraordinary complexity. Let's start arbitrarily with the vocal folds closed. We close them with an amount of force, adductory force, that we determine. You decide that. You then generate subglottic airflow, and when the air pressure overcomes the adductory force, the vocal folds move apart. from the bottom up and the top forward. I'm sorry. From the bottom up. And as the air passes, the Bernoulli effect of the passing air and the elasticity of the tissue cause them to close again from the bottom up, and then moving up along the vocal fold edge. So remember I told you it's not three-dimensional, it's more like fingers? The top and bottom of the contact edge of the vocal fold move differently. It's called a vertical phase difference. And it is important to normal phonation. If you lose it, you have some dysphonia and loss of efficiency. And that's why we try to avoid creating scars along the edge of the vocal fold. Now this happens up to 1,400 times a second in a high soprano. We have no muscle refractory systems anywhere near that fast. So this is not muscle. This is what we call a myoelastic aerodynamic system, in which the tissue characteristics and the airflow are responsible for those openings and closings. There's actually some advantage to that. It means that we can replace some of that anatomy, like a scarred vocal fold, with something other than the layered structure and still have it work pretty well. So let's talk about how we control a couple of things. Frequency corresponds with pitch. They're not quite the same thing, but they're similar. So how do we control pitch or frequency? Well, you already know that you recruit your superior laryngeal nerve and you fire your cricothyroid muscle and bring them closer together. It turns out that our voices behave differently at different pitches. So when you're assessing voices, you have to take pitch into account. At modal pitch, where we usually speak, the vocal folds are closed and open about equally. In falsetto, where we have people say, hee, the vocal folds don't meet. So if you do strobes on all of your patients and have them say a falsetto E, they'll all have failure of glottic closure. In glottal fry, the vocal folds are mostly closed and open in little bursts, and that's why when we examine people, we always do it at different frequencies and intensities. So we make a sound at the level of the vocal folds, which is called the glottal source signal, and then we pass it through our infinitely variable system of interconnected resonators, the supraglottic vocal tract. Based on the work of Dr. Sundberg and our friends in Sweden, we know that when you use the vocal folds only, you get a sound much like a trumpet mouthpiece without the trumpet. That kind of sound. Whether you're Pavarotti or Mortal, you don't have a great sound from the vocal folds. And it has a fairly boring acoustical signal. But once it runs through our resonator system, it looks like a beautiful Pocono or Rocky Mountain range with multiple peaks. And each of those peaks is called a formant. Those formants, you will hear more about later, are responsible for our personal vocal signature. They are what allow people to know it's you when you make a phone call. They're also responsible for audibility, particularly the singer's formant or speaker's formant, which allows you to go to a party or a bar or a sporting event and be heard and not be hoarse when you come out. For singers and actors, it's the ring in the voice, and it is a peak, depending on your voice, more or less around 3,000 hertz. If it is there, you're heard easily. If it's not very strong, you have to work harder to be heard. And that's nice because it makes patience for people like me. It's not efficient. So how do we control all this stuff? For fundamental frequency, we fire the cricothyroid muscle, we elongate the vocal folds, so it's not a big elongation, but it's long enough so that the subglottic pressure is acting over a larger surface. So it opens the vocal folds more efficiently. And the vocal folds are stretched a little bit, so they close more efficiently. So it happens more times per second, so the frequency goes up. and pitch goes up. How about intensity? Suppose you go to a wonderful lecture and you wish to applaud loudly at the end. You do this? No. So what do you do to get your voice louder? You increase your adductory forces. You increase your subglottic pressure. So when the vocal folds finally separate, they separate pretty far. You increase the amplitude of displacement from the midline. And they're bowed out. So because of the rapid airstream Bernoulli effect and the elastic properties of the system, they snap shut and suddenly interrupt the airstream. And you are loud. It is, of course, more complicated than that. But that'll be enough to get you to the people who come after me. So the answer is, who cares? I do. We measure this stuff every day in our patients in our voice lab. Take, for example, flow glottography. That measures the relationship between adductory forces and subglottic pressures in a way. And there are extremes. Breathy voice, pressed voice, which is the sound of a baritone announcing to the world that he is a baritone. That's also nice because I get patients from that group too. And flow phonation, which is what I hope I have been using. What's the difference in efficiency? Well, again, our friends in Stockholm have shown us that as we go from pressed phonation to flow phonation, we can increase. You can turn off the red light. I started 10 minutes early, so take it along. But not much. I still will finish early. Where were we? You can increase the output at the glottic source by 15 decibels. Is that a lot or a little? So suppose you're in a paper mill and they have a machine putting out 90 decibels and they turn on a second machine putting out 90 decibels. What do you have? It's not 180. It's 93. You turn on two more, you now have 4 of them, you're holding your ears. You're up to 96. How many machines do you have to turn on to get a 15 decibel increase? 32. So we're talking about a huge acoustic advantage when you stop pulling back your tongue and pressing. This is throaty singing. This is a form of pressed voice. Is that important? Yeah, it's important because the bottom line is people end up being patients of mine because they're trying to be heard. And if they are being heard by using flow phonation and by using their singers and speakers Formant and by using the system efficiently, and these are acoustic measures, they're heard and they do well. If they are not, then they use delicate muscles in the neck not designed for power functions to be heard, and the tissues break down. And that's how you make voice patients. We also assess vibration with strobovideolaryngoscopy, which you have all seen and will see throughout the week, and by laryngeal electromyography. So understanding all of this, the science, how the process is supposed to work, allows us not to give up our ears and our artistic analysis, but to supplement them with an articulate systems analysis based on an understanding of the oscillator, the power source, the resonator, and how they are supposed to interact. And it also gives us an opportunity to quantify some of those behaviors and interactions. So it gives us a whole new vocabulary with which to understand our patients and our students and to intervene. What it has brought us is rational thought to supplement our artistic impressions. And that has brought the world of voice in all of our specialties into the modern era. So, I thank you for your attention. I'm still 9 minutes earlier than my intended end time, and I will happily turn the podium over to Chuck Stanton, who's next. Chuck.